Well, it is quite an honor to present today's speaker, one of our own faculty, Dr. Jeff Haft, who is Clinical Associate Professor at the University of South Dakota's Sanford School of Medicine. Back in 1995, Dr. Haft achieved his Bachelor of Arts degree in Human Biology at the Stanford University in Palo Alto, California. In May of 1999, he received his medical degree at Oregon Health Sciences University, and in June of 1999, he entered the Integrated Orthopedic Surgery Residency Program at the University of Iowa Hospital and Clinics. He finished his orthopedics residency in 2004, and shortly thereafter entered a fellowship in pediatric orthopedic surgery and spine deformity surgery at the Starship Children's Hospital in Auckland, New Zealand. In 2005, he joined Sanford Health. Dr. Haft is first author of 11 peer-reviewed papers and has given many oral and poster presentations. He also serves as president of the South Dakota State Orthopedic Society. He is a popular teacher among medical students and our pediatric residents. I find him to be the consummate gentle person, an accomplished clinician and teacher who truly represents both town and gown. So please welcome Dr. Haft, who will pose the question: adolescent idiopathic scoliosis, do we still need to fuse those spines in 2020? Please welcome Dr. Jeff Haft. Take it away, Jeff.
All right, thanks, Joe. Yeah, this is the first time I've been on 4 million Zoom calls like everyone else has, but this is the first presentation I've had to give. My wife was trying to give me pointers on lighting sources and all kinds of crazy stuff this morning. So I said everyone's gonna be looking at their screen anyway, but thank you for that warm introduction. Thank you for the opportunity to speak today. I was excited to give a talk this year because something has finally changed in the world of scoliosis surgery. And there's some new information, there's some new news that I think we're trying to disseminate to primary care providers and even to other orthopedic doctors who may not have heard of these things yet. So we're going to talk about adolescent idiopathic scoliosis today, and I'm going to introduce the concepts of some newer technologies. And for those of you who know me a little bit, I do a lot of spine deformity surgery or scoliosis surgery in kids and adults. This is really my passion. I love it. I spend all my time thinking about this. I'm involved in national organizations. This is how I spend all my time. And since my wonderful partner, Jared Daniel, has joined me, it's given me the opportunity to hand over some big parts of my existing pediatric practice and focus more on spine. Now I'm going to try and advance this if I can, but I may have to. I don't see maybe there. There we go. So a couple disclosures. I have done some very minimal paid consulting work for OrthoPediatrics Corporation, but it's relevant because that company does now own ApiFix, which is one of the new technologies I'm going to talk about. I also was a member of a national surgeon committee that reviewed all of the European data for orthopediatrics before they purchased the ApiFix company. And of note, the FDA had previously reviewed this European data. Let's see here. Okay. So the goals today are to review objective imaging measures, which are Cobb angles that guide management of adolescent idiopathic scoliosis, review new FDA-approved non-fusion technologies for AIS, and these are vertebral body tethering, VBT, and posterior internal spinal bracing, which is ApiFix. So the way we measure scoliosis is with the Cobb angle, and this is the measurement of the coronal plane angle between the two most tilted vertebrae. So this is on a front to back x-ray. We take the angle between the two most tilted vertebrae. This Cobb angle and the patient's degree of skeletal maturity drive all of our management decisions in scoliosis. And we draw these on the electronic x-rays now. We don't use the wax pencils anymore. The natural history of scoliosis has largely been determined and published by Stu Weinstein, who is one of my mentors at the University of Iowa. His landmark publications are what drives everyone's decision-making in scoliosis. About 3% of the population will get a minor scoliosis, but less than 0.5% get a Cobb angle bigger than 20 degrees. And the curves that are bigger than 20 degrees are the ones that we're more concerned about. Cobb angles less than 45 degrees at skeletal maturity tend to remain stable throughout adulthood. And curves that are bigger than 50 degrees tend to progress slowly during adulthood at a slow rate of 1 to 2 degrees per year. Quick note, and this has also been done with a long-term study that was published in JAMA, patients do not die from scoliosis. So even if they're untreated and their curves progress, they do not get cardiopulmonary issues. They do not die from it. So they do get more deformity, they do have back pain, but they don't have shorter lifespans. Okay, so with that, this is what we always tell our patients: with adolescent idiopathic scoliosis, growth is your enemy. Curves progress most rapidly when patients reach their peak growth velocity. And peak growth velocity occurs prior to menarche and prior to Risser 1. Risser 1, the Risser sign is the growth plate on the top of the pelvis that we can see on a scoliosis x-ray. So if we're already seeing Risser 1 or Risser 2 on an x-ray, we know patients have already gone past their peak growth velocity. It's critical to know when they're going to have this, because if we're going to brace a patient, we want to start bracing before they reach their peak growth velocity. And on average, as you can see in the image on the right, that's around age 12 in most girls. It's a little bit later in boys. So here and just describe our typical management. So a Cobb angle, say 20 degrees or less, the patient is skeletally immature. We bring them back every 6 months. Every 6 months with a scoliosis x-ray. If the patient is skeletally mature, we say adios and they don't have to come back. So small curve, done growing, you go on with life. There's no long-term implications of these mild curves, no disability, no deformity. We never x-ray a scoliosis patient more frequently than every 6 months due to the cumulative radiation dose. And if you're following these in your own clinic, you only need a lateral image one time. So once and done, when they come back for follow-up, you just get the front to back PA image. You do not get a lateral, again, to minimize radiation. For Cobb angles in the medium range, 20 to 35 degrees, if they are skeletally immature, we strongly recommend bracing. And I'll get a little bit more into the bracing here in a minute, but bracing is something that we push as hard as possible now with incredibly strong evidence that it works. The number needed to treat with bracing to avoid a surgery is about 3. So if you put 3 patients in braces and they're compliant with the bracing, you're going to avoid 1 surgery for a patient. If patients are skeletally mature with a Cobb angle of 20 to 35 degrees, they follow up as needed. For bigger curves, we consider occasional x-rays later in childhood or early adulthood. For the bigger Cobb angles, 35 to 50 degrees, braces are less effective. In other words, it's harder for a brace to control these bigger curves. So if it's in the 35-degree range, we sometimes brace, but as they get bigger, that's not an option. We check them every 6 months. If the curve progresses, we talk about surgery. This is why it's critical to see the patients when their curves are smaller so that bracing is an option. So if you're following a patient, wondering when to refer them, if curves are approaching 20 degrees with a Cobb angle, that's when we would like to start meeting with the families. If the patient's skeletally mature, we check an x-ray about once a year until age 18, and then every 3 years during adulthood, and again, considering surgery if the curve progresses. And then Cobb angles greater than 50 degrees, these are the ones that are surgical. Traditionally, this is done with a posterior spinal fusion with instrumentation. This is the images you see on the right here. This is about a 50-degree curve that was straightened with a selective thoracic fusion with pedicle screws and rods. This permanently eliminates movement of the spine in the area that is fused, but it results in a great cosmetic correction and is very durable with excellent long-term outcomes. There are newer non-fusion technologies that we're going to get into, which are the vertebral body tethering and the posterior internal bracing, which is ApiFix. So bracing for curves with Cobb angles greater than 20 degrees, less than 35 degrees. It works very well, as I alluded to. It's dose dependent. It only works if the patient wears the brace at least 16 to 18 hours a day, and you must start before peak growth velocity. We brace aggressively. We have very good orthotists here in Sioux Falls, and our bracing successes have been tremendous. I think we have a pretty compliant patient population too. You tell some of these families that their kid has to wear the brace or they might need surgery, and they duct tape that thing to their kid's body. And we have very good compliance compared to my colleagues in some more urban settings. So posterior spinal fusion, this is a double major curve that went a little bit further into the lumbar spine with the fusion. But this is a mature technique with excellent short and long-term outcomes. The outcomes are best for selective thoracic fusions, which spare the lumbar spine, so you don't fuse into the lumbar spine. With spine fusion, a patient sacrifices spine motion for the correction of deformity, avoidance of curve progression, and cosmetic improvement. We can really level the shoulders, get rid of rib humps, get rid of waist asymmetry with fusion surgery. But it has problems. There are rare early complications, and we're talking in the 1% range of infection, heart loosening, or progression of the curve, back pain. The long-term issues are what you see in the images on the right, which is where the discs break down below the fusion, and you have to end up fusing someone to the pelvis like you see here. So this was a lady who had Harrington rods, broke down at L4-5 and L5-S1, and we had to go in and do a front back procedure to stabilize, decompress nerves, etc. With that being said, she did pretty well for about 35 years after her initial procedure. So the challenge is to straighten the spine without fusion and maintain flexibility, movement of the spine. It seems like a simple solution. Kids come in all the time and tell me that they have ideas about how we can do this without fusing their spine. And they're right. If you can straighten the spine with something mobile or flexible, the spine can still move. But the challenge is that mobile materials tend to deform, break, or loosen from the spine. So if you put something in there and it's moving, there's a good chance it's going to break. So vertebral body tethering is a concept based on the Hutter-Volkmann principle or Volkmann law. And this law states that bone under compression tends to slow down in its growth, and bone with distraction tends to grow more quickly. So when you have scoliosis, the reason that the patients get worse during their peak growth velocity is that the concave side of the curve slows down growth due to increased epiphyseal plate loading, and the convex side accelerates growth. So if you could do something like this, where you tether or retard the growth on the convex side of the curve with a epiphysiodesis, you could potentially take a curve that's on the left, slow the growth on the concave side, and end up with a straight spine. So that's the concept behind vertebral body tethering. And here are some examples of this. The image on the left shows a right thoracic curve with these screws in the vertebral bodies, and then there is a radiolucent tether that extends from the screw heads. As the patient grows, that tether can force that spine, force the spine into a straighter position. And then on the right, there's a double major curve where someone has done a right thoracic tether and a left lumbar tether. So I think in theory, it's a brilliant idea. Here is a model of this. You see the screws going into the vertebral bodies in the thoracic spine. And then you have this thing that looks like a shoelace. It's actually a polymer that goes from screw to screw, creating a flexible tether. And this is the idea. So in August of 2019, the FDA at the same time approved 2 different non-fusion technologies for use in adolescent idiopathic scoliosis. They were approved through the so-called Humanitarian Device Exemption, HDE. That is a humanitarian use device. These devices have full FDA approval, so they're not considered experimental. They have full approval. The device is intended to benefit patients by treating a condition affecting not more than 8,000 patients in the US per year. And it requires local IRB oversight, meaning that the IRB needs to know that you are doing these procedures and that you are qualified to do the procedures. So the specific FDA indications for use for vertebral body tethering, or the so-called the tether, is they must be skeletally immature. And so you can't use this if they're done growing or nearly done growing, because the idea is they must have ongoing growth to generate correction of the curve. They have to have progressive idiopathic scoliosis. They must have failed or be intolerant to brace wear. And they have to have a major Cobb angle of 30 to 65 degrees. Most of the FDA studies that were done for the tether were done in the United States. And there was meetings 5 years ago, there was a lot of excitement about this. But I would say the early zeal for the technique has been blunted by published early outcomes showing mixed results. First of all, the technique is challenging to surgeons. It requires lung deflation, thoracoscopic implant placement. So you have to deflate the lung, go through the chest wall, take down the pleura. There's a bit of bleeding. There's a lot of segmental vessels that have to be taken down, 3 to 5 hours of surgery, even amongst experienced surgeons who have done it a number of times. If you have to revise something, it's extremely challenging due to pleural scarring over the implants. We have no long-term outcome or even medium-term outcome. And we lack data right now showing that we're still maintaining sagittal plane motion after you've tethered the spine. So we aren't certain that we're maintaining motion at this point, although there are some studies that are going to be published soon that suggest that there is. The complication rates are dramatically higher than they are with spine fusion. So as people are learning this technique, every published study is showing complication rates, mostly minor complications, but in the anywhere from 25 to 50% of patients will have adverse events, pneumonias, chylothorax, hemothorax, pneumonia, curve progression, overcorrection. That's a common one where you put the tethers in too early, the patient grows. They start with the right thoracic curve and end up with the left thoracic curve. And some of these patients end up getting fusions anyway. So if you're meeting with a family, you have to be honest and tell them there's probably a 20 to 25% chance that their child's going to still end up with a fusion. Here's another paper where 20 patients reached skeletal maturity with a curve less than 30 degrees. This is a 75% success rate. But 50% of the patients had broken tethers. So as they got moving around, the mechanical properties of the shoelace that's in their back breaks up to 50% of the time. And there's concern that we're going to see the curves progressing again as tethers break. So we might need to develop a better implant. And 21 of the patients in this particular study required revision surgery. And by the way, these are the surgeons that are doing the early published results are some of the best surgeons that we have. So these are doctors who are very experienced and are trying to do the best possible job, and they're still not reporting incredible outcomes, in my opinion. So their high rate of complications compared with spinal fusion, including overcorrection, implant failure, reoperation, approach-related complications. However, the overwhelming majority of vertebral body tethering patients at 3 to 5 year follow-up appear to avoid spine fusion. I would say this is a promising technique with future improvements in implants and patient selection. So I think people are not going to throw in the towel on this, because the patients that do well do extremely well and they seem to love it. But I don't think it's ready for prime time quite yet. And just here's some examples of it. This is a patient on the top who started with a right thoracic curve, corrected almost dead straight by 24 months, but then has progressed to a left thoracic curve, but a minor curve, probably no big deal. I think most people would look at this patient and say, this is fantastic, great result. So not too bad. Here's one that they did a right thoracic tether, and then the spine kept tipping to the right, progressing, and had to be revised to a traditional fusion. So this was one that they did a big surgery on, watched him for 4 years, and then unfortunately had to transition to a fusion procedure. Here's another one that looked really good at 6 months and even decent at 12 months, but then the lumbar curve progressed, and looks like they went back in, removed the tether. This patient looks like they're on their way to a spine fusion at some point, potentially. So you've got the good, which is where you put this in at the right time, the tether doesn't break, you get a reasonable correction, the patient does not end up with a fusion. You get the bad, where you start with a right thoracic curve, you tether it, and then it starts going the opposite direction, so you get an overcorrection. And that's all I'm going to say on vertebral body tethering. We're going to move to ApiFix, or the posterior internal bracing. So the posterior approach to the spine is what we traditionally use for all of our spine fusions. So it's a technique that is very, very easy for spine surgeons to adapt to. And the concept of an internal brace has made sense for a long time. If you had something that had a little mobility to it, and you don't fuse the spine, you put a distractible apparatus on the concave side of a curve, jack it open. And if that implant can somehow grow with the patient, you might straighten the spine out, and then potentially, just like you discontinue a spinal brace at some point, you could potentially take this back out at some point in the future once the patient's done growing. So the FDA approved this device in August 19, also as a humanitarian use device. It's approved for both skeletally immature and mature patients, unlike tethering. So a person can be done growing and you can still use this. Curves between 35 and 60 degree Cobb angles, and the curves must be flexible. So we do side bending x-rays, they have to bend down to less than 30 degrees. And here's a direct sheet from the government. You don't need to know these types, but curve magnitude 35 to 60 degrees. They can be RISR 0 to 5, which means they can be immature or mature. They can't be overly kyphotic, and they have to be full. And we stick to these very strictly. So how does this work? So the distraction is applied across the concave apex of the patient's primary curve. So if it's thoracic curve, you put it in the thoracic spine. If it's a lumbar curve, you can put it in the lumbar spine. It can distract or lengthen further with patient growth. So it has a growing ratcheting mechanism in the body here in the shaft, which allows it to lengthen as the patient grows. And it has a unique screw rod junction that allows for movement where the screw attaches to the rod. And this would reduce the risk of screw rod fracture and loosening. And it also allows for some retained mobility of the spine as the child is getting through childhood. It's a posterior-based approach, which is simple and familiar to surgeons. It's a much shorter surgery than vertebral body tethering. I'll get into this more. We've done one case here now. I've never done this surgery before. So all the implants and the technique was new. It took us 60 minutes. And that was with us probably moving at half speed. And the patient was ready to go home 6 hours later, as opposed to traditional scoliosis surgery where they're there for 2 to 4 nights. And actually, if you look at the average length of stay for patients that have vertebral body tethering, it's 5 to 6 nights. and a couple nights in the ICU. So this is a different deal. The post, and I'm clearly, as you'll hear from this talk, I'm biased toward things that are simpler and lower risk. So it's a shorter surgery. The revision approach is very straightforward, with much less morbidity than going through the chest, taking down the lung, and opening the pleura again. So because this is new, just like vertebral body tethering, ApiFix has limited published outcomes. There have been 300 to 400 cases now done in Europe with 3 to 5 year outcomes. 82% of the patients in Europe with what I would say were relatively loose indications have residual curves less than 30 degrees. Very rare revision diffusion, less than 8%, 5 to 15% revision rates. Since it was approved in August of last year, COVID has slowed things down, but there, as of a week or two ago, there were about 15 implanted in the US so far. And here's a study in the US that's been published with some data from Europe and Canada, I believe, but 2-year minimum follow-up, 45 patients. Every single patient had their curve reduced to less than 30 degrees. There were 4 revisions due to some screw issues. None have been 2-year follow-up, none revised diffusion. So thought to be very successful. And vertebral body tethering and ApiFix, current status at Sanford. So I've been really excited about both of these technologies. I've trained to do them. I got involved with ApiFix with assistance from some other people a couple years ago because when I knew it was coming to the US, I wanted to be able to bring it to Sanford early. We're not really necessarily on the national radar screen, so I kind of had to push and shove and elbow a little bit to get in the room, but it's been really exciting. The IRB at Sanford has approved the use of both technologies by our group. We actually all of our ApiFix patients will be registered in a national multi-center registry studies so that we can follow their outcomes for many years, collect all the appropriate data, patient-derived outcome measures. We want to know exactly what's happening with these patients. We want to know exactly who's having a complication, what the complications are, what their life is like, whether they return to sports, what their flexibility seems like. With the internet, families are clamoring for these newer techniques, and that's where it gets difficult because you get patients, families, they hear about tethering, they come in, they want it. And you can tell them that there's high complication rates and that it might not be as rosy or that their child is maybe a better candidate for something else. But these are fascinating conversations with families as we have technologies and are trying to determine which patients are going to be best suited to a specific technology. So we have a number of patients waiting in the wings to get some of these new technologies as we work through the COVID epidemic. But next year, I think there will be a lot more of it. We did our first ApiFix case this month. These are the images on the right. And like I said, it went smooth as can be. Patient had minimal discomfort afterward. We actually kept him overnight, but I saw him a few hours after surgery. He was walking around and eating, and I thought he could go home today, really. And we'll see how things go over time, but I think his correction looks good on his immediate post-operative imaging, and we're optimistic. The take home from this talk, and I'm sure you can hear it as I describe these things, is I really think that the posterior distraction-based technology is going to prove to be a lot easier and a lot safer for patients than the vertebral body tethering. But there is a lot of enthusiasm for tethering as well, and we're prepared to use that technology. We certainly have the surgeons and the anesthesiologists in the ICU setting to do all of these things. So future questions: which technique is best and safest for patients? I think the technique on the left, which is our traditional fusion, is a tried and true method. Patients do great. They go back to sports, particularly when we're doing a fusion that does not involve much of the lumbar spine. The patients have wonderful long-term outcomes. The image in the middle is the tethering. The image on the left is our distraction-based internal bracing. I think the jury's out on both of these techniques, but I can tell you that we're going to reach a tipping point sometime in the next few years as we refine these technologies and potentially others, where I think a lot of our patients right now that are in the kind of 40 to 50 degree range of their curves, we're going to be trending toward non-fusion technologies. And I think patients are going to demand them. They're going to want to do something that's easier, safer, and that does not fuse the spine. And what I tell the families is if it doesn't work, they'll get the fusion that they were going to get anyway. So the backup plan is what they would have had in the first place, and sophisticated families can appreciate that. The flip side is patients, young patients, you're talking to a 14-year-old girl, they do not want to have more than one surgery. I mean, if they have a surgery and then 2 years later, you're like, oh, we got to do another surgery, there's a lot of tears, a lot of unhappiness. So I'm biased toward picking a technology where I'm sure we're not going to have complications, and I'm sure we're not going to be taking kids back for more than one operation. One last thing I want to hit on today is we are, and this is just something I'm kind of adding to this talk, is we have been trying for years to get some new imaging technology at Sanford called EOS, and we are likely going to have this in 2021. This will, at least as it looks like right now, will be located in the Vandermark building. And EOS is the standard imaging technique that's used at every major children's hospital in the United States for imaging scoliosis. And the reason that we use it is that the x-rays are actually much crisper, much better, and there is 90% less radiation. So we're going to have this technology for our patients. If you're local or even regional and you are thinking about ordering any spine x-rays on your patient scoliosis, I would encourage you to consider using this, even sending them over to Vandermark to get the x-rays done. The radiation that we expose our scoliosis patients to is not insignificant. And if we can reduce it by 90% with this new technology, I think we should try and use it like crazy. So just something that's out there. You'll hear more about this as it rolls out, but we've been trying hard to get this for a long time, and I think we're finally finding the capital dollars to make it happen. So thank you for coming to virtual pediatric grand rounds, the final 8 a.m. Thursday grand rounds, and I welcome any questions or comments that people might have. I know it's awkward to speak on these Zoom calls, but if there's any comments, I'm happy to entertain them. Let me see, there's a chat here.
Say, Jeff.
Yes.
This is Jerry Blake. Can you use that EOS technology for other conditions, for example, congenital deformities of the spine, or and do you get a lot more clarity with this than other technologies?
So yes. So the short answer is yes. I plan to use this technology for any X-ray that we can do, extremity imaging, and it does give much crisper imaging on almost everything. It's a more expensive technology. It's a little more cumbersome to get the patient into the setting to do the image, but yeah, the short answer is yes. You can image a lot of different body parts in the machine, and you can do head to toe imaging. Every place that's had one of these seems to get 2 or 3 of them, because pretty soon they find that everyone wants to use it for everything and that they don't have enough space in the machine. So a lot of institutions have 2 or 3 of these EOS machines now.
Does a patient have to be sedated to have this? For example, if you're doing a really complicated congenital deformity of the spine or something in a really young infant, does movement cause a problem in interpretation of the x-rays?
Yeah, I think with any x-ray, movement can be an issue, and because there is a little bit longer scanning time for EOS, there is the potential for wiggling in an uncooperative or a younger patient who can't do that. Again, I don't have enough experience with it to comment on all the details yet, just because we haven't had it here yet. But I do know that it's going to be once we have it, everyone that has it tells me you'll be using it for everything. And beyond the radiation difference, all the providers love the crispness of the images and being able to see things much better. So it's one of those things where it's hard for me to understand the physics of why we can get such a better x-ray and use less radiation. It's like magic.
Hey, Jeff, it's Daniel. Can you hear me, Jeff?
Yeah, I got you.
So the reason EOS works so efficiently is actually scans biplanar. So it scans PA and lateral in the same sequence. So that's why you can get a faster scan and get both the PA and lateral simultaneously. And it's also great from a deformity standpoint for lower extremity alignment issues, but I'm really excited for my aspect of the practice to help with limb deformity, because it's going to make things a lot easier to acquire those x-rays moving forward.
Yeah, I couldn't hear all that, Jared, but I know you were clarifying some of the conditions where it's really good, and you were, maybe other people could hear you better, but you were kind of going in and out. One other comment I'll make: Kurt Griffin did link a FDA comment on pre-market submissions and humanitarian device exemption, and how you clarify difference between full FDA approval and HUD. There's a lot of HUD exemptions in the world of orthopedics, and it's become more common for rare conditions where there's not enough data for efficacy to give full approval. That's not the HUD. And so what happens, and what I think will happen with these, is as more data becomes available, the companies will have to resubmit to the FDA for consideration of full approval. But this is a really common pathway that we see in orthopedics, and in particular in pediatrics, when there's a new class of implant or device that comes out. You usually don't have the efficacy and safety data because it's a rare condition, and you have to have sort of this intermediate category that they've created. But there is a link here that Kurt Griffin has nicely placed on the chat thread that people can click on and read. I don't want to misrepresent what this is, but it is an FDA approval category for humanitarian devices. So again, great future, I think, in scoliosis. I think that companies and industry are innovating to try and meet patient needs. I'm very excited about it. I think it's going to be, the next decade is going to be a lot of fun, and hopefully we'll be fusing a lot fewer patient spines over time between bracing and internal bracing and vertebral body tethering. Hopefully we can get away from so many fusions. Let me look on the thread here, see if there's anything else.
Okay. Thank you, Jeff. I
Good. All right. Thank you.
concludes the day. Thanks for that talk, and enjoy the holidays.
Thank you, everyone, for attending. I really appreciate the opportunity, and have a great holiday season, and we'll see you at noon o'clock in the future.